It's a pleasure to introduce our first speaker of the afternoon, Dr. Elaine Husni. Dr. Husni is Vice Chair of Rheumatology and Director of the Arthritis and Musculoskeletal Center. She's a staff physician in the Orthopedic and Rheumatologic Institute at the Cleveland Clinic. Dr. Husni is also an associate professor at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. And I'm sure, as all of you know, she holds a lot of leadership titles in professional organizations around the country and around the world. I'm lucky enough to spend time with Dr. Husni in our combined rheumatology-dermatology clinic, and it's a pleasure to introduce her. She's going to talk to us about selecting management strategies in psoriatic arthritis and spondylosing ankylosis. Dr. Husni.
Thank you, Tony. So I'm truncating my talk a little bit and focusing on psoriatic arthritis, but we can also talk about AS as well. And I'm going to be followed by Dr. Magrey and as well as Dr. Shet again. So we'll be able to talk about spondyloarthropathy. Here are my list of disclosures. This is actually one of the very first patients that I saw in one of my derm room clinics in Boston when I first started these interdisciplinary clinics. And what I like to put up this picture is just, it reminds me of sort of all the unanswered questions we have. It's really interesting how areas of psoriasis are next to, they're really well demarcated and next to areas of totally normal skin. It's also interesting that the nails that are the most effective are also where the joints are the most severe. It's also interesting that there's just, no rhyme or reason to, where we see highly destructive joints, like in this thumb of telescoping. So a lot of sort of unanswered questions, really a unique disease as well. So today I'm going to just focus more on not so much all the drug treatments that are available, but really just management. Thank you. Really identifying some of the influences of how we select our management, how we evaluate the risks and benefits, and exploring what I think has been really helpful in my own career, and that's being in a very interdisciplinary setting. So Tony has taught me a lot about skin diseases, and I think it's really helped our patients in these combined clinics. So sorry, it's not advancing. So I want to, highlight some of these boxes. I won't have time to go over all of them, but we all know that it's important to have early diagnosis, important that the earlier we use some of these treatments for our more moderate to severe group, it makes it easier for their treatment outcomes to be better. Treat to target we heard about also today, or targeting a low disease activity state. And then how frequently do we want to see back our patients? And then, we just heard from Dr. De Silva and Dr. Cohen about individualized or more personalized medicine. And then, of course, adding the patient into the picture. So I'm going to start with a case, Annalisa, who's a 29-year-old female who is currently studying to become a nurse. She's single, and she complains of this intense itchy rash on her arms, on her legs, on her torso. She's pretty used to it because she was diagnosed with psoriasis as a teen. But when she was growing up, it was pretty intermittent, her flares. She had used some topicals, maybe some light therapy. She wasn't even sure if it was helped. She did notice during college it really flared a lot, but she's never really been put on any additional medications. She now comes back with a little bit more sort of pain in her wrists and her hands. She has an hour of morning stiffness and a lot of fatigue. Her blood pressure, unfortunately, has been on the high side. She is overweight. She finds it hard to exercise. On exam, she does have a diffuse rash with scalp involvement and some nail changes. Her wrists and MCPs are tender, and she now complains of some left heel area swelling and tenderness. Her labs are essentially CBC, CMP were normal, but her sed-rate CRP were slightly elevated. And somebody else checked a HLA-B27 before she came to see me, and that was positive. So she really complains about her psoriasis. She says it's really coming back and a lot more bothersome. She does not really like to use her creams. She sometimes wakes up at night and notices that her sheets that she's been bleeding. and she wants to know what she can do to help herself. So we see a lot of patients like this, and we always ask ourselves, how do we look at her disease activity? What do we do first? What factors do we take into consideration? So just as a synopsis, she's, has long-standing psoriasis. She's not really aware of there's a connection with these joint symptoms. She has scalp involvement. Her body surface area is probably about 10%, but her workup was largely unrevealing in terms of, mostly normal labs except for inflammatory markers and normal radiographs. So what do we know about assessing? So we have two major areas, the rheumatology, joints area, and then we have the skin, which I don't have time to go over, but many of us know we have ACR criteria, we have DOS, we have things that we do in the clinic, things that we do in research. One of the things that have really been changing that I just want to highlight really quickly is that most of our targets now and psoriatic arthritis is really looking at ACR 50. And that's because, as you know, these ACR response criteria was really made for RA and just really borrowed for psoriatic arthritis. And many times it doesn't reflect all the domains that we see in our patients. And we are now, raising the bar a bit. And, although there's still ACR 20 measures, we really look sometimes for primary endpoints in the ACR 50 change before we would, really reflect an important change for these drugs for psoriatic arthritis. In terms of dermatology, very similar. There's many different ways to measure this. There's, things that we use in clinical trials, things that we use in the office as well. So I'm going to take a step back and just, go over a little bit about skin disease and skin psoriasis and how we quantify it. So this kind of gives us a gestalt, and many of us know that if it affects around the size of your palm, it's about 1%. In the mild category, it's anything less than 3%. And then as you get more and more plaques, you can see that a BSA, a body surface area of 3 to 10% would put you in the mild range, and then a PASI of 10 to 15. And she, I told you, has lesions on her legs, on her arms, and on her scalp. So she has about a body surface area of 10%. So I don't know if that would change how you talk to a patient, how you think about managing her. And really, I rely a lot on, dermatologists to help also educate our patients because, they need to understand also what is mild, moderate, and severe so that they can communicate with us. And in this particular case, I told you she had scalp involvement, she had nail involvement, and she has greater than 2, 3, 4 sites that are involved. And so that puts her at a little bit higher risk for getting psoriatic arthritis. And, it's interesting because many times I see these patients and there's really not that connectivity that these are one part of the disease, and sometimes they don't come to see us as soon. And so it does take, a team to kind of teach and change the way that we are presenting us as physicians to patients. So at this point, what is some of the therapeutic approaches that you think of, or what would you recommend in this patient? So she has pretty severe skin disease, and it sounds like she's getting some joint involvement. So there's a couple ways that we have in the literature that will help us look at this. There's the TICOPA trial. And so this is looking at tight control specifically in psoriatic arthritis. And just like in rheumatoid arthritis, it's showing that the more regular you see these patients reaching a target, even if you don't have consensus to a target, finding some target that you use consistently has shown that the outcomes are better than not using a tight control population. So this really helped us understand that, patients need to be seen, they need to have a target, and we need to make a decision if they're not reaching the target that we want. We also have a ton of guidelines, which I don't have time to go over, but we do have the ACR and PF guideline. We have EULAR as well as GRAPPA guidelines. I will go over some of the differences between them, but this is what we have currently that will help guide Annalisa. So looking at the ACR guideline, this was really unique in that it did include patients. And one of the highlights for this is that it recommended that TNF be the first line for naive treatment patients with PsA. So this was big news because many of us start with oral DMARDs, and this is from the first time a recommendation showing an active PsA patient that hasn't been on any other treatment, that you would start with a TNF. And then if they had persistent active treatment, then you have choices of either switching to an IL-17, switching to a different TNF, or even other mechanisms of action. Then there's also the GRAPPA guideline, which is a little bit more international. And as you can see here, it's domain driven. So you see all these different domains. And depending on which domain is more prominent, you would then go down that list. And they also have in the paper, when you read, a large, how influence of comorbidities as well. So really great guidelines done by really great people in the world of psoriatic arthritis, but yet, sort of different treatment algorithms. So let's look at some of the similarities. They definitely all, as I mentioned, the TICOPA trial really support the treat to target approach. They do have patient voices on the voting panel for these consensus. And the differences are, I think, really interesting. So the ACR NPF guidelines are really looking at one scenario over the other and what you should use, drug A versus drug B. While GRAPPA, the international guidelines, are really looking at more of a step-up approach. Like I said before, the ACR did make a splash in that they are really recommending TNF inhibitors as the first line for DMARD naive patients. And then GRAPPA is really has a little bit more of the domain strategy, a little bit more about the prognostic factors, where you would just, go down the algorithm faster if they had poor prognostic factors. But do these really help us? Is this really the end all be all? So once you follow the guidelines, you're done. And as we all know in practice, we're really not, we are making decisions way beyond what the guideline and what TICOPA trials have taught us. And that's because it takes a long time to synthesize these guidelines. Many of you people in the room are probably part of these guidelines and know that you have many meetings. And by the time everything is done and published, there's a new treatment that's out and available. There's also some lack of head-to-head trials, which is what we really want. I know in the psoriasis world where, Tony lives, there's just a lot more, head-to-head. We have a few, and I can talk about those as well. But it would be nice if we had access to more of these. So if guidelines don't help, what else can we do about the next management? So some of it is also the way that we practice and how comfortable we are with certain medications and classes of medications and how we approach. So we do have a lot of comfort level with methotrexate oral DMARDs. We also have been, since 1995, been using TNF inhibitors. And then now we have an explosion of other biologic DMARDs that we can choose from. So here's just a little bit of a highlight really quickly. If you look at the green boxes, those are all the ones that are approved for both psoriatic arthritis as well as spondyloarthropathies, ankylosing spondylitis. In the red, those are more specific to psoriatic arthritis. So there's a lot out there. So going back to Annalisa, she sounds like she has a little bit more skin involvement at this time. And so probably at 10%, we'd probably be having that conversation that we're pushing her more towards the, moderate severe class, more towards the biologic DMARDs. So the question is, all of these have shown efficacy in both skin and joint, and how do we think about, where we would go first? So TNF inhibitors, I'm just highlighting some, there's, as you know, 5 different ones. I'm just highlighting some of the skin and joint so you can see across different trials. IL-12/23 or ustekinumab is also has some efficacy in skin and joints, but we all know that in terms of the joints, probably not as robust as TNF, but in the skin, there's some good efficacy data. And as we know, the delivery of this is really nice because, you're doing it, you're having much less injections throughout the year. Safety profile is good. Then we look at the IL-17s and IL-23s. We know that those skin-wise has really been a game changer. It's really, really high PASI scores. People in rheumatology are jealous because we don't really have similar drugs that do as well. But in terms of joint data, we know that IL-17 can be pretty comparable The IL-23s may be a little bit less robust. There is some radiographic outcomes that we see in the IL-17 inhibitors. So each one of these do present with good things and not so good things. So still making the decision not so straightforward, but really nice to have options. So the other thing we look at in Annalise's case is, does she have any comorbidities that we would filter out that would help us, with all these different biologic DMARDs? So I don't have time to go over all of these, but many of us know that psoriatic arthritis, axial spondyloarthropathies are associated with many comorbidities, as you see here. So we now are, as rheumatologists, are becoming mini cardiologists, mini GI people, and mini ophthalmologists, because we see these patients, we care for them, and we are sometimes the first line to look for screening. And although it would be nice if we could, rely on all our colleagues in every specialty, but, then they'll be going to all these doctors' visits. So many times we're the ones screening and trying to figure out whether or not some of these issues are going to bubble to the top and where we might filter through the treatment option. So in Annalise's case, it looks like she may be having more metabolic syndrome-like symptoms. And then she was also being treated for depression and anxiety, and that might sort of help filter or kind of unpack as you're going down the list for management issues. So she was started on a TNF inhibitor. She had good results for about a year, but then her skin disease, and then she started acting up, and she would have a little bit more low back pain. So after the initial TNF inhibitor, what would you recommend now? She's in your office, and as you all know, there's options, right? So you could plan to just cycle through another one. You could stay within class. You could swap out for something else. And so the optimal sort of TNF failure probably remains a bit unclear, because many of our data that we take from this is from more observational trials that we look at. Switching to another may have some benefit. Could anti-drug antibodies play a role? Is this an area that we're going to start looking more closely at? Is switching to a non-TNF with a different mode of action the first thing you do after you are, sort of petering out on the first TNF? And the choices, as I just had mentioned before, could be filtered out based on comorbidities and other things in the patient's history. So I'm just going to highlight, one study just looking about switching and does this happen? So in this Dan Bio, we know that up to 40% of patients do switch to another TNF. So it's happening, at least based on some observational data. We also know, if you just kind of look at the colored bars really quickly here, so just looking at the first half first, looking at first, second, and third switch of TNF, what's the first thing you notice? You notice that the second and third switches are just less efficacy. And then if you look to the other side of the bar and looking at, if any number of switches after 2 years, so it looks like people are switching, and the question is, we probably don't switch to the third and the fourth and the fifth, but I think maybe switching to the second TNF may help, or switching to a different mode of action. So what about methotrexate? Is that another option for a patient that's not doing well on TNF inhibitor? Would there be a role in psoriatic arthritis in adding methotrexate? So we know from rheumatoid arthritis that there's clearly studies that show that combination with methotrexate does improve a patient with RA. However, in psoriatic arthritis, it's a little bit more unclear. So I raise 2 boys who are really into Star Wars, so that's my life. So everything is around this. So we have a nice study by Phil Meese looking at this. It's called the SEAM trial, trying to highlight, well, if we're using etanercept and methotrexate, if does really methotrexate augment etanercept? And here, what we see in ACR 20, 50, and 70 is that in combination, etanercept with methotrexate doesn't really, you can see the lines are superimposed. It doesn't really add to the outcomes for psoriatic arthritis. So this is really different from rheumatoid arthritis. And so something to think about, although many of us do know that methotrexate does help and work, and we still use it in our patients, but I just wanted to highlight this trial. So I think it's still unclear. There are trials that I don't have time to go over, like the MIPA trial, which was the first placebo-controlled trial in methotrexate for psoriatic arthritis, that actually showed that methotrexate was not better than placebo, but there's a lot of caveats to that trial. It used very low doses of methotrexate. It took a long time to enroll. And then we also have other trials that, like the RESPOND trial that showed that methotrexate does help. So I think it's not as clear as we want it to be. So what else do we have? We also have some head-to-head trials finally in this space of psoriatic arthritis. And do they push us further to know our management algorithm? So we have the EXCEED trial and the SPIRIT trial. So these have been really nice to highlight. We have secukinumab versus a TNF, and we have ixekizumab versus a TNF adalimumab. And interestingly enough, the EXCEED trial did not meet its primary endpoint. They looked at a primary endpoint of ACR20, and when they were looking at this secukinumab versus adalimumab, it did not meet its primary endpoint. If you look at the SPIRIT trial, ixekizumab versus adalimumab, they was able to meet their primary endpoint, and that ixekizumab did better than adalimumab. However, there's some caveats. They used something called a co-primary endpoint. So what they did was they looked not only at the joint score of ACR 50, but they also measured a PASI 100. And so we do know that the IL-17s do really great in skin. So skin might have been driving some of that response. So it's really great that we have head-to-head, but there's still a little bit of uncertainty of how to interpret and whether or not how we apply that to the patient that's in front of us. We just had a great talk on JAK inhibitors, so I won't go into it, but this has been, really exciting because a lot of the JAK inhibitors have been approved in our space for spondyloarthropathies. So that's nice to see, and the more to come. We also have a TYK2 that has been approved for psoriasis, but we don't have as much experience yet in psoriatic arthritis or AS. We also, just to remind you that this patient had a little bit of low back pain. She had a positive HLA-B27, but she didn't really have classic inflammatory back pain at this time, but she's probably at higher risk. So the reason I bring that up is because this MAXIMIZE trial did look specifically at axial involvement for psoriatic arthritis and whether or not that those patients may present differently than axial SpA patients. And so more to come on that, but this particular study looked at the efficacy of IL-17, specifically in axial patients with PsA. And, there's probably some differences that we will better understand over time. And then I just wanted to end a little bit with what do we know about, having two doctors instead of one seeing a patient? How do we know that's really better other than just spending more time with the patient? So this was a study that I did back in 2012 when we first looked at the first sort of 500 patients that sort of came into our derm room clinic that we co-managed. And we found that about 46 of them, almost half of them, had a revised diagnosis when seen in combination versus individually. We noticed that we had about a third were diagnosed with psoriasis and about 20% with psoriatic arthritis. So this just gives us a little glimpse of, care in an interdisciplinary setting. We also looked at some of the treatments that they had prior to the combined clinic and then after the visit. And so we looked at, did their topical use change, did their systemic medication change, or biologic medication. So there was a lot of changes in their medication compared to being treated individually versus being treated in a combined clinic. So I think there's some evidence to show that perhaps doing some of these in certain patient populations can improve their patient outcomes. There's also a PAC-Man, which is run by Joe Marola, looking at combined clinic models throughout North America. And what is nice about Pac-Man is Tony and I get a chance to look at, be with people who have multidisciplinary clinics elsewhere and learn from best practices in developing validated tools together and looking at referral patterns and how we can make these interdisciplinary collaborative clinics better. And then I'm just going to end with, Annalisa also is complaining of a lot of fatigue, and many of us, get these patients, and sometimes we feel a bit inadequate because we can treat skin and joint disease, but yet some of these symptoms, such as fatigue, are a little bit more difficult to treat. And we know that lifestyle modifications can be an important part of these treatment algorithms. And Len and I have been very interested in how to motivate, measure, move the needle for patients, looking at many different lifestyle factors such as exercise, nutrition, sleep, mindfulness, and being together and having friends and social connectiveness. This is just a quick glimpse. We are just starting an online study called Immune Strength, looking at an online way to attract patients to create better habits to help their disease process. So this is not another visit for them. This is something that they can sign up on online, where we go through different modules to help them get through some of these lifestyle modifications. And we're hoping that, there's just really not enough time sometimes to see patients on a visit. So we're always hoping that people can find creative ways to get them treated. So despite all of these, and we're going to hear from Dr. Magrey and Dr. Shett about these diseases, but none of the new therapies that are out are really demonstrating any more superior in terms of joint disease. And so I think we still have a ways to go in terms of PASI 100 that we see in the derm. So I think the management and treatment algorithms are still evolving, but it's really exciting that we do have new medications that are out there. So thank you.
Our next speaker is Dr. Marina Magrey. Dr. Magrey is Division Chief of Rheumatology at University Hospitals, Cleveland Medical Center, and a professor at Case Western Reserve University School of Medicine. After she received her medical degree from the University of Kashmir, India, Dr. Magrey completed an internal medicine residency and a fellowship in rheumatology at the Cleveland Clinic. Her scholarship focuses on the management of axial spondyloarthritis, psoriatic arthritis, and metabolic bone disease to improve outcomes in patients. And she developed a disease-specific clinic for spondyloarthritis in a prior role at Metro Health. Nationally, Dr. Magrey is considered a thought leader in spondyloarthritis, and she serves on the board of Spondyloarthritis Research and Treatment Network, or SPARTAN, and she is co-chair of the American College of Rheumatology Subcommittee for Abstracts in Axial Spondyloarthritis. Today, she is going to speak to us about the effectiveness and safety of tapering strategies in axial spondyloarthritis, highlighting real-world evidence. Dr. Magrey.
Good afternoon, everyone, and I would like to thank the organizing committee to give me this opportunity to talk about this interesting and somewhat controversial topic, tapering biologics. Every time I come to Cleveland Clinic, I feel like I've come back home. 30 years ago, I landed in Cleveland in 1993 here, and Cleveland Clinic was my first family. I developed strong connections with people who have been my sponsors, from mentors here, and I really feel like that I'm back home when I come here. So, significant advances have been made in the last 2 decades in treatment of rheumatic diseases, and particularly axial spondyloarthritis. We rheumatologists have developed treatment strategies in order to bring our patients into clinical remission. Now, with these successes, we currently face some challenges. Is it time to taper biologics off of our patients who have been on them for several years? Is it safe to do it? And with that background, I'm going to touch upon some real-world and clinical trial data which has tried to answer this question, whether it's time to taper biologics, is it safe to do it, what are the concerns, and ultimately, is it really feasible or practical to do it in our everyday practice? Now, being a clinician, I would like to start with a quick case. I have a 35-year-old white male who was diagnosed with ankylosing spondylitis about 3 years ago. He was HLA-B27 positive. He had radiographic sacroiliitis, also had uveitis. His CRP was normal at the time of diagnosis. He was initially treated with adalimumab. He did fine for a year and a half, then noticed recurrence of his uveitis on that. We switched him to certolizumab. He was getting it at 400 milligram every 4 weeks and was stable on it for another year and a half. And then his question to me was, can I stop the treatment? I feel good. Do I still need to continue taking it? How long should I be taking my medication? So we will leave the case there. I'll come back at the end of the talk, and we'll do some show of hands and see what everybody would like to do with this case. 2019 ACR, Spartan and SSA guidelines were published, and they conditionally recommended against tapering or discontinuation of biologics. The reason for that is the data were very scarce at that time. They were weak, and there was concern that if we take our patients off of biologics or taper them, they're going to flare their disease. So they conditionally recommended against doing that. What that means is they said, don't do it. It's left between the physician and the patient what they want to do. Right before those guidelines were published, there was a systematic review that was published looking at anti-TNF discontinuation tapering in patients with axial spondyloarthritis. This systematic review involved about 8 studies that were tapering and 5 studies that were discontinuing TNF inhibitors. The tapering studies involved mainly patients with ankylosing spondylitis. They were predominantly males that were HLA-B27 positive. About 5 of these studies had patients on etanercept and 1 on infliximab and 2 on adalimumab in combination. And the median follow-up on these studies was about 12 months. And what they were looking at is how long would these patients stay in remission or low disease activity after tapering TNF. And what they found was the duration was very variable. It was short. It was only between 3 to 6 months after tapering biologics, these patients flared again. These were the discontinuation studies. They were also mainly observational studies, 5 of them. These studies included patients both with ankylosing spondylitis and non-radiographic axial SpA. And most of these studies were actually with 3 of them were with etanercept, 4 of them were with etanercept. And then what they found was they defined flare. The flare in these studies was basically defined if the BASDI score was changing by 2 or if the overall score was greater than 4. They found that the high percentage of patients, anywhere between 75 to 79% of these patients flared when the TNF inhibitors were discontinued. And time to flare was variable. It varied anywhere between 6 weeks to 15 weeks in this patient. So basic conclusion from this systematic review was discontinuation is not possible. Flare rate is very high. Tapering may be possible, but the duration in which these patients stay and low disease activity was very short. So it didn't last that long. You tapered them, they did fine for 3 to 6 months. 6 months back later, they flared again. So based on those, these kind of data, ACR guidelines, 2019 guidelines, conditionally recommended against discontinuation or tapering. Moving forward to 2022, when ASA's EULAR recommendations were published last year, for management of axial disease, they put in a new recommendation, recommendation 13. They said, if a patient is in sustained remission, tapering or biologic DMARD can be considered. So it was changed now from 2019 to 2022. So what changed between these years that this new recommendation came up? So that's what I'm going to talk about in the next few slides. What evidence do we have that's suggesting that we may be able to do some stepwise tapering of biologics in PsA and axial SpA? There was, in Denmark, Dr. Husni also mentioned, in Denmark, all patients that take biologics are actually registered in a registry, and that registry is called Dan Bio Registry. So in 2017, in Denmark, they took like this systematic, this approach, uniform approach. They said all those patients that have been on biologics, on the same dose of biologics for about a year and are clinically in remission as per the clinician who's taking care of them, that we can try to reduce their dose of biologics with the aim of keeping them on the lowest dose of TNF inhibitors and without having any flares. And so the aim was to reduce any adverse events in these patients, at the same time cost containment. So this study was they undertook this study in patients with axial SpA. This was called DOBIS study about dose adjustment in biologics in this. So these patients should not have had any disease activity in the previous year, and they would have to stay on the stable dose of same biologic dose for a year. And clinical remission here was defined on a scale of 10 to 100, a BASDAI score of less than 40, and a physician global score of 40. 109 patients were enrolled in this study. 78, you can see, predominantly they were kept on the standard doses of their current regimen, and then only about 28% of them were assigned to this reduced regimen. So those patients that flared went back to their original dose, and the primary endpoint in this study was they were looking at what proportion of these patients can actually be tapered and what proportion can actually be discontinued. They were doing a stepwise tapering. The stepwise tapering was every 4 months they were tapering them. So this 1/3 of these patients at the baseline were on this reduced dose. So let's say they were on adalimumab. So the standard dose was 40 milligrams every 2 weeks. At baseline 1, the small group were reduced to 2/3 of the standard dose, which was 40 milligrams every 3 weeks. And then 4 months later, they reduced it to 40 milligrams every 4 weeks, which was half of the standard dose. And then ultimately 40 milligrams every 6 weeks. And if they could do that for 4 months, they could discontinue it. Similarly, it was done for certolizumab, etanercept, and golimumab. The stepwise tapering was also recommended because they felt if the patient flares, you can go back to the last effective dose on that patient. So what they saw at the primary was only 52% of these patients were successfully tapered, and out of those 52%, only 14% were actually down to 50% of the standard dose. In terms of discontinuation, only 1% can discontinue. The flare rates are very high in those patients that discontinued. So this study again showed discontinuation was not an option in these patients, but some of them were able to reduce from the standard dose, but only small amount could go below 50%. They also looked at predictors of successful tapering. How could we gauge which patients can be tapered? Earlier talks were on precision medicine, so this was something like that. So they found that, they did a univariate analysis and then a multivariate analysis, and then those patients who were on standard dose of TNF inhibitors, in multivariate analysis, the only variable that showed that patients can be reduced was physician global assessment of disease activity. If their physician felt that this patient can go off, that only came as a predictor. Then they took all the patients, both that were on TNF inhibitors, standard dose and reduced dose. 3 variables were looked at, and one of them was current smokers were more likely to get off. And I think this is a fluke because smoking actually is a risk factor for increased disease activity in ankylosing spondylitis and also a predictor of progression. Maybe it was the sample size was small, but physician global assessment of disease activity once again came back as a predictor of successful tapering. And also if the patient had low inflammation, the low SPAR scores in the SI joints, that was another predictor of successful tapering in these patients. So less inflammation, more likely one can taper the dose, or if the physician feels that this patient is really going to be. So so the take-home message from this study was discontinuation is not possible. About half the patients could be tapered, but overall sample size was small. So there was only 30 patients to begin with that were tapered. Then there was another study that got published last year. This was a pragmatic open label real world study. It was a randomized control study that included both patients with axial spondyloarthritis and psoriatic arthritis. These patients had to be on a stable dose of TNF for 6 or more months with low disease activity. And then they were randomized 2:1. The intervention arm was the tapered arm, where they were tapering the TNF, and the regular standard dose was the control arm. And the definitions for low disease activity was ASDAS less than 2.1 for AS, and for psoriatic arthritis, it was PASDAS less than 3.2. And here the tapering strategy was little bit, they were more aggressive than the previous study. This was a study done in Netherlands. They were reducing tapering every 3 months. And the primary endpoint in this study was that they were looking at proportion of patients between these groups, the intervention group, which was tapering group, and the control group, and trying to see what proportion of patients stayed in low disease activity in these two groups. And this was the tapering, it was similar. Tapering regimen was exactly similar in them. They first reduced them to like 2/3 of the dose, then they go to half the dose every 3-week interval. For adalimumab, 4-week interval, the doses get changed. But this was done much more rapidly. They had about 122 patients in this study. 81 were actually 66% were actually in the tapering group, and about 1/3 of them were in the standard dose non-tapering group. So what they found was the proportion of patients at low disease activity between the intervention arm and the control arm was not different, 69% and 73% between those. So there was no statistically significant difference between the two groups, that suggesting that tapering is a possibility. They looked at the cumulative incidence of flares, and they said there was no difference between the two groups that was tapered and the standard dose, but look at the flare rates were high, 85% in the tapering, and they said 78% in the non-tapering too, so it was not significant. So they felt that this is a possibility from this study. And at 12 months, 72% of these patients of tapering group were successfully tapered, and they said 28% were able to discontinue. And there was not a big difference in the disease activity between this group. So this study was a little bit more favorable, suggesting that tapering may be a possibility in these patients. This was another Danish study, biologic dose optimization study. This study had more patients, 142 patients, and included patients with rheumatoid arthritis, psoriatic arthritis, axial spondyloarthritis, and most of these patients were either at a similar standard dose at the baseline, or they were then reduced at 4-monthly interval. They were reduced to the 2/3 of the dose, then 8-monthly introduced half, and then ultimately they would stop. And the primary endpoint in this was a little different. They were looking at what proportion of patients can actually reduce their biologic below 50%. Even if we taper, how far down can we go in the dose? So that was the question they were trying to answer. And what they found was there was no significant difference between the two groups in disease activity at 18 months, the tapering and the standard dose, but only 37% of these patients were able to get below 50th% dose of the standard. They could not do that. So drastic dose reduction may not be a possibility. So that has to be kept in mind, and flares were still higher in the tapering group. Now, complete discontinuation of biologics has actually been studied in clinical trials, post-hoc analyses of a large of these clinical trials. Most of these clinical trials were done in patients with early disease, non-radiographic axial SpA, except C-optimized, where we had patients both included with the non-radiographic and radiographic axial SpA, and coast-Y. The design of these studies was very homogeneous. They all started with an open label period where every patient got the medication for up to like 24 to 28 weeks till they got to an inactive disease status, which is defined as ASDAS less than 1.3. So they felt that the disease was inactive. And after that, they were randomized either to the placebo, the drug was taken off, or they continued on the original dose of the drug for about 40 to 48 weeks. And the primary endpoint, they were looking at what percentage of patients were going to flare that continued on the medication compared to the one that went on placebo. Obviously, all of these studies showed that those patients that continued on the medication, the flare rate was much lower. So the ReEMBARK, which was the study with etanercept, they said, the flares in the placebo arm started as early as 16 weeks, and only 25% of patients in that arm were flare-free, the placebo arm. In ABILITY-3, 70% of patients that continued adalimumab stayed flare-free compared to 47% of patients that went on placebo. And in C-optimized, similarly, they showed, I'm going to talk about C-optimized in another study in a minute because it also had an additional arm. And the coast-Y was the only study we have with IL-17 inhibitors, ixekizumab, and 83% of patients receiving ICSI were flare-free compared to only 45% that went on placebo. Now, C-Optimize also had an additional arm that was they reduced the dose of certolizumab. They didn't completely discontinue it. They had three arms. One was the standard every 200 milligrams every 2 weeks. They reduced the dose to 200 milligrams every 4 weeks, and then the placebo arm. And what they found there was that those patients that continued on the full dose and those continued on the reduced days, there was not a big difference in flare rates between the two groups, 84% to 79%. This study was just published. This was a study with golimumab study, similar design, period 1, where it was open label. Then those patients that got into inactive disease status were then randomized to 2 different doses of golimumab, either 4 weekly or 8 weekly or to the placebo. And the results were similar to C-Optimize study, where they showed that those patients that stayed on golimumab or those that were tapered, they did not have much difference in flare rates compared to placebo. Placebo arm is high. Now, one can argue, they can say, one of the reasons why patients in the studies flared could be because they did not stay in inactive disease status for too long. So the two things are important, not only the disease state, but it may also be very important how long these patients stay in inactive disease status before we decide to taper medications. That's a possibility here. But good thing was that those patients that went on the reduced dose also had low flare rates based on these clinical trials. There was another meta-analysis that was published, which also looked at risk of flare. Now, we know risk of flare is very high in patients that discontinue. But what is the risk of flare in patients who go on tapering dose? And what they found was that relative risk of patients who tapered was also high, not as high the patients that discontinued, but it was about 1.45. And persistent flare rate was about 1.56, even in patients that were tapered their dose from the standard dose. So this is important to discuss with our patients, because the patients need to know this, that, okay, if we want to reduce your dose, it's a possibility, but you should be prepared. You may still flare on a reduced dose. But definitely those patients that discontinue, flare rates are much higher, because we basically don't cure these diseases. So I don't think we are in the position to tell the patient that they can stop medication. So that brings us to this another important question. One of the presumed advantages of tapering biologics is that the patients perceive that they have lower risk of side effects, and it's biologically plausible that it can happen in these patients. But what did we actually see in these trials? Most of these trials did not show a difference between the risk of adverse events between the patients that continued on the standard dose or on the reduced dose. This meta-analysis had included 13 control trials of spondyloarthritis and rheumatoid arthritis. And if you look at this forest plot, there is not a big difference in serious infections, serious adverse events, cardiovascular events, or malignancy risk between the two groups, whether they stayed on the standard dose of biologics or whether they reduced the biologics. That if you look at the incidence of serious infections, it was 1.7 per 100 patient years in the tapered group compared to 2.6 in the usual care. And serious adverse events were 7.4 per 100 years compared to 6.7. So they were not statistically significant difference. So this concern that the patient has that they're going to be, if they reduce the dose, they will be better off than taking a standard dose. I think most of the adverse events, if they're seen initially when the treatment is started. Once if patients have, been able to tolerate the medications, I don't think it then makes a difference later on. So that brings me to the last part of our question, which is very important. So when should we consider tapering? In our clinical everyday practice, when a patient asks us, can I go, off of my treatment or reduce, when should we? So the answer everybody says is patients should be in an acceptable and stable disease state. Those should be considered for tapering. So two things are important: the disease state, stable disease state, and how long they have stayed in that disease state. So what is an acceptable disease state for axial spondyloarthritis? Everybody will say a sustained remission is considered to be an acceptable state. But believe you, we don't have any consensus or a uniform definition of remission in axial spondyloarthritis yet. The 2022 ASAS-ULAR guidelines, they recommended that use SDAS inactive or low disease activity for at least 6 months. This was based on expert opinion. This is not an any consensus definition, so we really don't know if that's right, but this is what they came out. They said if they have been in low disease activity with an SDAS less than 2.1 or an inactive disease status with an SDAS less than 1.3 for 6 months, you could consider tapering. So the question is disease activity guiding tapering a valid measure? Should we be relying on disease activity? Majority of these studies did rely on disease activity, either on BASDAI or on SDAS. Most of them used an SDAS less than 1.3 or 2.1. And one would say that inactive disease status would be preferable. But if you look at the clinical trial data, it's only 1/3 of our patients who actually get into inactive disease status. 2/3 of our patients in those trials never get into inactive disease status. So getting to inactive disease status in real world is not easy. Even in the real world pragmatic studies, it is even less than 1/3 of our patients who actually get into inactive disease status. There were a couple of studies that were comparing these disease duration, the disease states, where should be the patient be, whether they should be in inactive or low disease activity. One study showed those who are in inactive disease status, they're better off than those with low disease. Another showed no difference. So the jury is still out. We don't know the answer. Whether should it be less than 1.3, should it be less than 2.1, that still is unknown. This was recently published, a very interesting, looking at remission and low disease activity from patients' perspective. And in this study, they found there was no agreement. The agreement was very poor between patients' perception of reception and a physician's perception of reception. In this study, they did, I think it was out of the DESIRE cohort from France. They said 21% of patients, they perceived they were in low inactive disease status, 21, compared to 46. So much higher, we as physicians perceive our patient is in inactive disease status much often compared to our patients. And as was discussed earlier, this could be because patients also take into account their contextual factors, other forms of pain, depression, anxiety. The disease activity which correlated best with patient perception of inactive disease or remission was BASDAI less than 2 and normal CRP. If the BASDAI was less than 2 and CRP was normal, that is where the patients felt best. So a huge disagreement between the two. And in reality, when they were measuring the SDAS in these patients, only 9% of these patients were SDAS less than 1.3, even though 46% of the physicians thought they were in inactive disease status, but in reality, only 39. So there is a huge discrepancy here, what we perceive to be remission as physicians, what the patient perceives to be a remission. So what should we be doing in this case? So do we have a target? This is an interesting, I think most of you in audience must now be familiar with this data. What is our target in axial spondyloarthritis? This was a study that was done a few years ago and published. The TACOPA study in psoriatic arthritis did show treat to the target is, improves outcomes. This study actually did not reach its primary outcome. The primary outcome was 30% improvement in ASAS health index, and they could not reach in this study. There was these patients, there was some things showing that patients who were followed quickly every 3 months, they could get to the low disease activity of 2.1 SDAS score, but the primary outcome was not reached. And is it really feasible in our practices every day that we can bring our patients every 3 months, change treatments and say, we're going to bring you to inactive disease status? It's not at all practical. It is difficult even to bring our patients every 6 months to come and see us back, and then having them come every few months and evaluating their medications and reaching. So I don't know what the target is. We don't have a well-defined target yet. And a lot of contextual factors also drive pain, and that we still need a better outcome to see where we're heading towards this. Now, one would say, in addition to disease activity, it may also be patient characteristics which determine success or failure of this tapering. Several studies tried to look at predictors of successful tapering. Unfortunately, there were no uniform predictors of success or failure. Negative predictors of tapering, they said female sex in one study. They said females are less likely to be tapered compared to men. The C-optimized study said HLA-B27 negative may be a poor prognostic factor for tapering. Obviously, if patients hire physician global, if the physician feels that this patient has high disease activity, we may not be able to taper them, and high CRP level. Looking at predictors of discontinuation, if the patient has high disease activity, whether measured by SDAS or BASDAI at the time of discontinuation, they're more likely to flare, or if they have baseline high inflammation on an MRI or high CRP levels. Both of them are considered to be poor prognostic factors in these conditions. So now coming back to our case, so this is the patient. He wants to now get off. This is the patient with AS who was doing very well as per the patient, and he's asking me, can I get off of the medication? He's HLA-B27 positive, he's a male, he has a normal CRP, and he has uveitis. So from the show of hands, who would want to continue certolizumab at 400 milligram every 4 weeks? Just yes. There's no right or wrong answer here. It just depends on how you want to do it. Who would like to decrease the dose to every 4 weeks, 200 milligram every 4 weeks? Okay, so we got few people saying they would like to decrease. Who would like to discontinue certolizumab? And who would like to go even further than 50% dose reduction, give it to every 6 weeks? I got only 4 people saying they're comfortable reducing the dose to every 4 weeks. And let me tell you something, you know, we have shifted to patient-centered care. And whether we tell our patients not to change, the patients like to do what they want to do. So when they're in the office, they tell you that I want to get off of this medication. You have to strike some balance between what advice you're going to give and what the patient is going to do. So what I did with this patient is because he was young, I didn't want him to stop the medication. So I actually told him, I don't want you to stop the medication because I'm concerned that your uveitis may come back. And if you keep on getting these attacks of uveitis, you are at a risk of losing your vision. And so I did strike a balance. I said, well, let's cut the dose down. You don't have to do it every 2 weeks. You can do your injection every 4 weeks and we'll monitor. But keep in mind that you can flare and you can get uveitis and then we may have to start all over again. So I'd like to conclude by saying that, you know, there is increased risk of flares with discontinuation of biologics in axial SpA. So discontinuation may not be a possibility. We still don't have uniform tapering decisions. They're still lacking. Stepwise dose reduction may be an option in certain patients with inactive disease status. Neither remission criteria are well-defined, nor the time interval that this patient needs to be in remission. How long do we keep this patient? A year? Year and a half, 6 months, we still don't know the answer to that. So we need further research to explore optimal tapering and discontinuation strategies. And ultimately, we have to have patients buy in what we do. The patient has to agree with our recommendations and to have a good relationship with our patients. Thank you so much.